You're watching the Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, drug-free therapies for pain. With us, we have a double board certified physician. He's board certified in anesthesia and interventional pain management. With us, we have Dr. Dobecki. Dr. Dobecki, welcome to the program.
Thank you.
Now, for people that don't know your practice here in San Diego, who's a typical patient and what are the different, services you offer?
Well, our overall goal at our clinic is to alleviate pain. We take patients from all backgrounds. Most of our patients have spine pain. Our goal at our clinic is to alleviate pain and get patients off of medicines and back to life, improve their overall functioning, and improve their quality of life.
Okay, then one of the things I think your goal is to get people off drugs. You say you have a sign or something.
Yes.
Like that. What does it say?
Our motto is get back to life.
Get back to life.
That's correct. And our overall goal, again, is to find ways to help patients restore their identity, return back to life, get back to their jobs, interacting with their families,
okay.
All the things that they do and enjoy, but that are often sidelined by pain.
All right. Now, so specifically we're talking about drug-free therapies. So some people, do they come to you and they say, I don't want drugs?
Correct.
Okay. So specifically questions about neurostimulation. What is it? Who's a candidate? And how does it work?
Yeah, exactly. Neurostimulation has been around for 50 years. It's nothing new to medicine, but it's often the best kept secret in medicine. Neurostimulation is great because it allows patients to have a long-term sustainable therapy that doesn't develop tolerance, that doesn't have many side effects when used appropriately. And if we have the patient that responds to this type of modality, they can often get off their medicines and get back to work, back to functioning, all the things they enjoy to do.
So you have people that are on heavy medications that because of this neural stimulation, they're off their meds. You've had that happen?
Yes, absolutely.
Okay.
So we have patients that have been on very high dosages
like
of pain medications, over 300 milligrams of morphine equivalents per day, which is a very high number. It's enough to probably anesthetize a horse. So
wow.
Our goal is to get patients off of these medicines. These medicines have never been shown to last and provide long-term pain therapies in any kind of study. So the goal for these types of therapies is to get patients off of their meds, get back to qualities of life, get back to their families, get back to their physical activities, and get off of these medicines that are just downright dangerous and probably not good for them long-term.
Okay, so this neural stimulation, is it also electronic stimulation? Is that the same thing?
That is correct. Yeah, there are many
how does
forms.
it work, though? I mean, what is it?
Yes.
How does it block the pain? That's the part.
What this does, it's a two-step process. Part one is we test it usually right in the surgery center, and it's an outpatient procedure. They can test this therapy for a week, essentially. Okay. What we do with this therapy is we allow them to go home with a device. It's partially implanted, partially external, meaning like having an IV in your arm. Okay. Part of it is internal, part of it is external. They get to go home with this device, and they get to come back after a week and tell us if it works. So it's a real-time test. There's nothing like this in medicine. You can actually test drive the system. If it works for them, then we remove the temporary device and we implant the full system. The full system is a long-term device. It consists of a battery that's about the size of an Oreo cookie and a wire that's about the size of a angel hair pasta spaghetti string, essentially. What that does is it blocks the transmission of pain from their limbs, for example, to their brain. So it takes a signal that is an abnormal signal, that is meaning pain, could be noxious, could be burning, could be aching. What it does is it takes that signal, changes it, converts it essentially at the level of the spine, and sends up a new signal in place of the pain.
Okay, so is this is done in your office or in a surgical center?
Office or the surgery center.
So it's implanted, like this little Oreo cookie type of device, size device, is implanted, and then the stimulator is stimulating the spinal column,
cord.
The cord.
Exactly. So it goes in no different than...
Is it tingle? It must tingle. So you're replacing pain with a tingle?
There's a couple ways we can do this. One option, and the traditional option, is to replace it with a tingle. And patients say that often feels like jacuzzi jets or massage or something pleasant. The other option is to change the frequency where we can actually make this so high-pitched, essentially, for the spine that the spine cannot detect any stimulation whatsoever, but it can actually take away the pain. So it's almost silent, per se.
Depending on the level of pain that they have. Okay, so who is a candidate? Like what type of pain? Like sciatica?
Exactly.
Low back pain, neck pain, what?
Low back pain, sciatica, pain in the neck, pain in the limbs, essentially, certain types of headaches, neuropathy, diabetic neuropathy, etc., postherpetic neuralgia. There's many, many, many different types of what we call neuropathic pain. Neuropathic pain is basically pain that's from nerve dysfunction.
Mm-hmm.
This is different than stepping on a tack. This is different than osteoarthritis of your knee. This is different than a pinched nerve from a herniated disc. These are patients that usually have nerve dysfunction.
Okay.
And this is long-standing pain that is not responding to traditional therapies.
All right. So with these patients that have sciatica, or you described a patient that was on these high dose of morphine.
Correct.
Right? Enough to
tranquilize a horse,
okay.
usually.
Why weren't they given the option, or were they, to do this neurostimulation procedure?
Well, they may not have been to the right doctor.
Is that what it depends on?
That's correct. So if I explain this type of therapy to a traditional doctor, a family practice doctor, an internist,
okay.
Even some neurosurgeons, they don't have a very good understanding of this because it's almost like modern technology, cell phone technology, computer technology. It changes so fast that something that was new 5 years ago is now obsolete. So this is evolving rapidly, and the pain specialists like myself are on the forefront of this with research, development, product design, etc. And we are immersed essentially in this type of culture, this milieu of
okay.
product development.
So tell me how it normally works. Okay, so somebody's in pain, the path, maybe their internist, they're over 50, over 60, their internist may handle, or the primary care physician may manage their pain, right?
Correct.
And give them the minimum amount to avoid addiction of some sort. I don't want to put words in anybody's mouth, but is this kind of what happens?
Usually what happens is the classic scenario is a patient comes to me and they're already on some sort of medication, usually an opiate. Many times the referring physician is only comfortable prescribing a certain amount of medicine, or maybe the patient has had many interventional type of therapies. A lot of times they'll arrive to me through a referral, and then what we do is we assess the patient and then look at their past medical history, look at any diagnostic imaging studies, determine that they're not a candidate for surgery. If they're not a candidate for surgery, we've deemed them to have this neuropathic pain. What we do is we then taper them off their opiates and then test this type of system.
They go home with the stimulator.
They go home with the stimulator for a week, exactly.
And it either works right away or it doesn't.
They'll know right on the table as soon as we turn it on, like turning on a light switch.
Then why send them home if you know it works?
Yeah. So the beauty of this, and one of the best kept secrets, is you get to have a functional test. So lying perfectly still on the table during the test is not a direct representation of the patient living, interacting with their family, walking the dog, going to the store, etc. So we want the patient not only to have the pain relief on the table, but we want to know that this is going to make a huge difference in their life. So we send them home and say, do all the things that you can't do. Do all those things that hold you back because of the pain. So we allow them to do that. They come back, they get a pain diary, and then we assess that diary and look for at least a 50% reduction in their pain.
On the ones that it really works for?
Yes.
What do they say after that week of going home with it?
The patients actually come back and they're slightly upset and depressed because they're afraid that they're going to go back to the pain once I take the stimulation out. And to me, that's actually music to my ears because I know that this is a slam dunk. When a patient says, "Doctor, I'm so upset because this is the last day of the test and you're going to take the system out, I have to go back to the pain that I was on, I have to go back to the medicine."
But it's covered by insurance in most cases?
That is correct. So this is covered by Medicare and all insurances.
Okay. And so would you say that there's tens of thousands of people just here in San Diego that could qualify for this type of therapy?
Yes.
That aren't being exposed to this type of therapy?
Yes. So these are patients that have chronic pain, chronic spine pain. Chronic spine pain is the actual number two reason to see a doctor in the United States. And it's the number one admitting diagnosis, spine pain in general, to a U.S. hospital. So we are talking about huge, huge numbers. Direct costs of spine pain annually, hundreds of millions of dollars. So there are patients all over the place, loved ones, family members. We all know somebody who's had spine pain.
Let me ask you a question. Are they coming to you like late? That means, would you like to get them earlier upstream? That means that it gets to the point the internist or the primary care physician can't handle it anymore, and the patient's complaining, and then you get them when maybe there's a lot of damage done?
Yes. Unfortunately, we don't get to these patients soon enough. So a lot of times I'm the limb out on the tree branch here, and they've extended through all types of care and therapies. A lot of times I'm their last resort, their last ditch effort.
Could you be a first-line therapy?
Certainly, in many cases, yes.
Well, let me ask you this. If you have a lot of money, maybe you're an athlete and you get this, are you usually a first-line therapy in those kind of cases? Before drugs, because those people can't take drugs?
Absolutely. So for patients that are having an option between chronic narcotic therapy and interventional therapies, for example, neurostimulation, we absolutely believe that neurostimulation is a much more viable long-term treatment option than chronic opiate use.
I mean, it doesn't work for everyone. it's like logically to me, it's like, why not give it a try,
That's,
right? If
that's
it's nerve
exactly it. Yes, that's the beauty
Interesting.
of the trial, is we can test the system and see if it's going to work. Really, there's not a lot of harm or foul. Either it works or it doesn't. It declares itself very easily, and you can know right then and there if this is a sustainable therapy.
We're out of time. Great stuff. How does somebody find out more about this? And how do they get access to you? Do they have to get a referral from their primary care physician?
Yes. So we usually take a referral from a primary care physician or a surgeon or some sort of healthcare provider in general. They can contact us via our website, our phone number, etc. We are sandiegopain.com, www.sandiegopain.com, and we are all over the internet. We have a website. We have telephone, fax, whatever.
Could they go to you directly if they wanted to?
Yes. So they could. If, for example, they don't have a primary care physician, we could certainly review the case on a case-by-case basis and take a patient without a referral. Absolutely.
Okay, good. You know, we will have doctors that will stumble onto this show. What do you want them to know about you, especially the San Diego doctors? A lot of the primary care physicians, the internists, etc.
Yeah, there is an alternative to opiate therapy, number one. Number two, there is a way to get back to pain, get back to life, to regain their identity, and to help patients improve their quality of life. Life can get better, absolutely.
Okay, good. I want to thank you for coming to the show. Very interesting.
Thank you.
Good stuff. You've been watching The Wellness Hour. I'm Randy Alvarez. We'll be right back.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.